And then brain hemorrhage. So there are two main subtypes of brain hemorrhage. There's intracerebral hemorrhage, which refers to bleeding directly into the brain parenchyma. And then the subarachnoid hemorrhage, which refers to bleeding into the cerebrospinal fluid within the subarachnoid space that surrounds the brain. So intracerebral hemorrhage, the most common cause of an ICH, the most common causes are hypertension, trauma, bleeding diastasis, amyloid angiopathy, illicit drug use, and vascular malformations. The first signs of an ICH correspond to dysfunction of the part of the brain that contains the hemorrhage. So bleeding into the right putamen and internal capsule region causes left limb motor and or sensory signs. Bleeding into the cerebellum causes difficulty walking, and bleeding into the left temporal lobe would present as aphasia. Neurological signs may not begin abruptly and are not maximal at onset, unlike in the case of an embolic stroke. And then headache, vomiting, and a decreased level of consciousness develop if the hematoma becomes large enough to increase intracranial pressure or cause shifts in the intracranial contents. These symptoms are absent with small hemorrhages. The clinical presentation in this setting is that of a gradually progressing stroke. And then in subarachnoid hemorrhage, which is bleeding into the subarachnoid space, mostly secondary to the rupture of an aneurysm and vascular malformations. Bleeding diastasis, trauma, and illicit drug use are also possible causes of a subarachnoid hemorrhage. So the symptoms of a subarachnoid hemorrhage begin abruptly. The sudden increase in pressure causes a cessation of activity. So there'll be like memory loss or loss of focus, or the knees will just suddenly go weak. And then a headache is always present and is typically instantly severe and widespread. The pain may radiate into the neck or even down the back into the legs. Vomiting usually follows soon after onset. There are usually no important focal neurological signs unless bleeding occurs into the brain and CSF at the same time. So diagnosis is confirmed preferably by brain imaging, but in the absence of brain imaging, an LP can be done, which would show CSF xanthochromia, which we have a picture of there. So medicine treatment of a patient with subarachnoid hemorrhage as taken from the standard treatment guidelines. You need to maintain normal hydration and electrolytes. You need to control the blood pressure. We avoid NSAIDs. Recommended analgesia is stated as paracetamol, 500 milligrams to 1 gram, 4 to 6 hourly. And then if there's no response to paracetamol, then you give morphine IV to a maximum dose of 10 milligrams. In all patients with aneurysmal subarachnoid hemorrhage, while waiting for transfer, in consultation with a neurosurgeon, nimodipine per os 60 milligrams 4 hourly for 21 days should be given. Right, so referral, you refer all patients with impaired level of consciousness, and then patients initially deemed unsuitable for further investigation may be referred at a later stage should their condition improve. And then blood pressure management in the case of a patient with subarachnoid hemorrhage. So blood pressure lowering runs the risk of cerebral hypoperfusion. And also an elevated blood pressure increases the risk of bleeding. So the optimal blood pressure management is actually unclear. UpToDate recommends that BPs more than or equal to 180/120 be gradually reduced. Specific targets are individualized based on severity of initial blood pressure, the presence of brain swelling, and risk of kidney impairment. For most people with acute subarachnoid hemorrhage, a target systolic blood pressure less than 160 millimeters of mercury and a diastolic blood pressure less than 110 millimeters of mercury is used. IV labetalol, nicardipine, clavazepine, or enalapril are preferred. This decision, however, should be made in consultation with a specialist. All right, so a multidisciplinary team is very important when managing patients with strokes. It's not enough to